Hello, everyone. Welcome back to Healthcare Experience Matters. Today, our guest is Dr. Craig Joseph, and he has a new book out that we're going to be talking about Designing for Health, the Human Centered Approach. And I want to ask a lot about that book and also just technology's evolving role in improving patient experiences, which, of course, we're very interested in hearing about. Dr. Joseph, just first and foremost, tell us about your professional background and kind of how you got to where we're at today.
Sure. Well, first of all, thanks for having me. I'm a pediatrician by training. I trained in Detroit for medical school and residency, and then practiced primary care pediatrics for about 9 years before hearing the calling of technology and healthcare. My undergraduate degree was computer science, and so I was kind of a nerd before it was cool to be a nerd. And ultimately, I was able to kind of combine that tech background with the healthcare experience that I have, and moved to Madison to work for a big electronic health record software vendor. Did that for about 7 years, and since then been working for either hospitals or consulting companies or both at the same time. And so, kind of helping with the adoption of technology for clinicians in general, but physicians specifically.
Very good. And I want to now talk about your book, Designing for Health, the Human Centered Approach. We were just chatting about it before we hit record on these microphones. And why don't you just back us up and tell us a little bit about the book and what you expected to accomplish by getting it out there?
Yeah, well, a colleague of mine and I, doing some of this work, again, focusing on technology and healthcare, had seen the same mistakes happening over and over across the United States. And that mistake chiefly was that folks that were designing the technology, designing workflows, sometimes even designing hospitals or clinics, didn't take into account how humans actually think and behave. So they didn't really think about, at least not intentionally, the human-centered approach, the human-centered design approach to healthcare. And so the goal of the book is to really focus on those healthcare leaders and to say, hey, you need to be intentional when you're thinking about either implementing a new technology or configuring a technology, or really thinking about anything that you're designing, either creating or redoing, and being thoughtful about not trying to make it easy to do the wrong thing. So we've seen people say, "Oh, I wonder why the patients aren't paying us on time. Why won't they pay the copay, or why won't they do the pre-registration, or why won't the doctor order the medication that we think is best for the patient?" And sometimes the answer is, well, you made it difficult for them to do that. And so you shouldn't be wondering why they don't do that. There's a lot of clicks involved, or it's very unintuitive. And it's much easier if you just kind of go with the flow, understand some of these basic principles of design, and everything starts just to work a little bit better. It's easier.
Yeah. And before I keep moving along here, I do want to make mention that there was a co-author on this book too. Did you want to just tell us a little bit about your co-author and the kind of the process of how the research and writing went into this book, seeing as though there was two authors?
Sure, sure. So Jerome Pagani is my co-author and colleague. He's got a PhD, and so he's kind of comes from a more formal science background. Or at least that was our joke, that I was the MD who had a lot of practice experience, and he was the one who had a lot of the academic and scientific bench experience. And so, kind of put together, we thought it brought an interesting perspective. And so certainly, we reference some of the science in terms of how humans think, how they behave. We are more alike than we care to, and predictable than we care to acknowledge often. And so there's some science in the book, but there's also a lot of real world practical advice from folks who have been doing this for a long time.
Yeah, definitely. And of course, we've talked a little bit about your patient care background. And I'm just curious if there was ever like a light bulb moment or just a story or any part of your career when you were in clinic where you were like, hey, I can actually make a bigger difference for patients by kind of leaving the traditional care and then going to work on kind of fixing some of these technical, technology issues that you were seeing. Was there a moment where you kind of like discovered that?
I would say that there's probably a bunch of them. One, and it actually wasn't a technical problem, but one kind of design flaw that stuck, basically hit me in the face, was I had a patient who had asthma, and this was a young patient, was too young to have to use an inhaler, and so we used a machine called a nebulizer, which took medication and kind of turned it into a mist, and then the parent could hold this mist in front of the patient, and they would breathe it in. And so back in the day, this was the late '90s when I'm talking about it, it was a little difficult to get someone a nebulizer at home. You had to jump through a lot of hoops. I had to call an insurance company. I had to call a third party to go and deliver and show the parents how to set up the nebulizer. It's a lot easier now, but it was complicated back then. And so we said, well, this patient really needs this nebulizer. So we jumped through the hoops and I gave her a prescription for the medication. And lo and behold, she brought the child back to me a couple times, wheezing, and said, he's not getting better. I'm giving him the medicine. And then we gave him a breathing treatment with our nebulizer in the office, and he got better instantly. And I didn't have a good explanation for it till maybe the second or third time it happened. And my medical assistant spent some significant time with the mom in the room and said, why don't you show me exactly what you're doing? Show me exactly how you put the medicine in the machine and how you turn on the machine and all of that. And as it turned out, she wasn't actually putting the medicine, the albuterol, into the nebulizer. What she was putting was the diluent, which was just salt water or normal saline. So what she should have been doing, and what we assumed she had been taught to do, was to take the diluent, the normal saline, the salt water, and combine it with the albuterol, mix it up a little, and then go to town. And somehow that there was a little confusion there, right? And so all the patient was getting was salt water. And it's certainly not shocking that her wheezing symptoms didn't get better with just the salt water, and certainly makes complete sense as to why when she came into the office she was better. Now, fast forward to today, where that's impossible to happen, and the reason that will never happen is that the medication is now mixed. It comes pre-mixed in an ampule with the saltwater diluent and the albuterol together. And so that was kind of an aha moment. That was a design flaw. I mean, we should have seen it coming, that someone was going to confuse that. And certainly, I'm sure it happened all over the country, not just to me. But that idea of, boy, what can we do to make it either very difficult or impossible to do the wrong thing? And kind of applying that to technology sometimes is the same. Like, hey, you've made this a very complicated screen. There's a lot going on. Or, hey, there's three choices here, but we typically see people choose option one, which we think is really the best. Why don't we default that in? Why am I having to always choose this option? Just make it the default option. And every now and then I'm going to change it, but most of the time I'm just going to go with it. Those kinds of things can really make a difference. They're tiny little details, but they can really make a big difference in a clinician's life or a patient's life.
I really appreciate that story as someone has given their child a nebulizer within the last year or so. It is easy, a lot easier than you're describing how it used to be. So wow, that I didn't know any of that.
The
Eh,
olden days, the olden days.
yeah, no, it's great stuff. I mean, it's still really not easy to give your child a nebulizer because at least my son was not a fan of it being on his face and all that.
Yeah.
But that's a great example of technology improving, medication adherence, that type of thing. How about advancements in the clinic, like when the patient and the provider are interacting? I know we've talked a little bit about the use of medical scribes on this podcast, and
Mm-hmm.
some of the AI advancements that might make that improved soon, if not already. What are your thoughts in that department?
Well, again, applying some of these basic principles of design, you can think about it. You can certainly think about it from a tech standpoint, but even just basic, hey, where's this monitor? if the doctor is looking at the, or the nurse is looking at the computer screen, and that computer screen is not visible to the patient, boy, that's really annoying, right? And because you're often having a conversation and the doctor's asking you questions, or making sure that the information that they're seeing is correct, but they're not looking at you, they're looking at the screen. And we know from studies, actually, I found this very interesting, that if you share that screen, so again, that room has to be configured so that both the patient and the clinician can look at the screen at the same time. When you're doing that, when you're sharing that screen, when we ask the patients later, how much time do you think your doctor or nurse spent looking at you eye to eye? And we record that, so we actually know the answer to the question. But then we ask the patient what their perception was. They've said, well, all the time that they didn't say this, but in fact, what they were thinking was the time that they were sharing that screen, even though they weren't looking at each other, they were both looking at the same screen. They perceived that as eye-to-eye contact with their clinician, right? And so again, is this a high-tech thing? No, it doesn't really matter how expensive that screen is, but if the screen is off in the corner and the doctor's forced to kind of be looking at that and then looking at the patient, it's a horrible kind of a human to human interaction. And so something as simple as that. Certainly you were talking about AI and scribes, and I think the future is going to be that we probably won't need scribes per se, because we'll be having ambient listening. So you go to the office, there will be a little box in the corner that will be recording everything, maybe for a long time, maybe for 5 minutes. I'm not sure how long that recording will be kept, but an AI can generate a note. It'll identify who the people are in the room, when the doctor's talking, when the patient's talking, and be able to kind of create some of that documentation now that either the physician has to do or the scribe does, in terms of assisting the physician. So I think we're certainly moving in a much better area. There's concerns. We're not really there yet. There's some privacy concerns about recording a conversation, a clearly very private conversation. But I think we see the writing on the wall, and it would be so much better than having the physician have to do this documentation themselves. It takes a lot of time. It contributes to burnout. It reduces that physician-patient interaction. And so I think good things are coming, but we're right in the middle right now.
Dr. Craig Joseph is our guest today on Healthcare Experience Matters. We're discussing Designing for Health, the Human Centered Approach. It's his latest book. And I do want to leave you a chance to give us some final thoughts. If there was anything else of value regarding today's discussion that you wanted to add, please go ahead and let us know.
Yeah, I would say again that these are not complicated concepts that we're talking about. We have one chapter called "Gross," which sounds odd, but in fact it stands for "Getting Rid of Stupid Stuff." And this was the title of an article in the New England Journal of Medicine, where a hospital system just went around asking their doctors and nurses and therapists, "Are there things that we make you do?" mostly in the electronic health record, that are just stupid from your perspective. They just dumb. And then they acted on those, right? And we're transparent, which is another design principle, being transparent. And so they said, oh, okay, yeah, thank you for bringing that to our attention. That was an oversight. We didn't mean to do that. We're going to fix that. Or they said, oh, that's actually not stupid. That actually makes sense. You just don't understand how we're using some of that data that we're asking you to generate. And so kind of explaining the why makes you kind of go very far. And the third big category was, yeah, we agree with you. It's not great, but we don't have any choice in it. We're not able to fix that at this time because it would require a law change, or the technology is not there or something. And so, just again, this concept of getting rid of stupid stuff makes a huge difference in either a patient's life or the clinician's life. And so that's what's in the book, these kind of very, very basic, seemingly obvious things that just we're not doing. And if we start doing, we're moving in the right direction.
Once again, the book, Designing for Health, the Human Centered Approach, will have a link to that in the description of this podcast. You can also follow Dr. Joseph on LinkedIn. He's a great follow there. And I just really appreciate your time and all this insight today. Thank you again, Dr. Joseph.
It's been my pleasure. Thanks for having me.